So part of what our work is to address the quadruple aim in Kansas City. So we are focusing on better health outcomes, better patient experiences, lower costs, and better provider experiences. And we want this for patients and populations. Our vision is to bring multiple stakeholders together to improve the quality and value of healthcare. Kansas City QVIC is supported by our partners at BioNexus, UMKC NextGen, KU Frontiers Clinical and Translational Science Institute. And we are really a learning healthcare community. We have multiple stakeholders in the realm of healthcare leaders and providers, community-based organizations, researchers, payers and purchasers, policymakers, the public health community, philanthropy, and industry, all serving our community, which are patients. And it's important to know that knowing is not enough, we must apply, and willing is not enough, we must do. So we have several different strategies to improve healthcare value in Kansas City. And to date, we've had several activities that center around three major focuses. So our first area, we've got two projects, and they focus on regional quality improvement. Our two projects are Casey Epic, and which is our opioid project, and our second is our Transitions of Care for Heart Failure project, which focuses on addressing social determinants of health for heart failure patients. We have also developed the training and implementation actionable research approaches, and are currently looking for additional ways to educate investigators, quality improvement personnel, and others about implementation and the methods behind implementation. We're actually in the process of working with several different partners at the University of Missouri Columbia, University of Missouri Kansas City, and KU Medical Center to develop formal coursework in that area. And finally, our forum, which is a strategy for engaging our communities and stakeholders through the dissemination of information that is important to you and provided by members of our community. So today we are talking about healthcare delivery evolution in response to COVID-19. I do want to highlight that next month, our forum time and date changes a little bit. Typically we hold these on Thursdays from 3 to 4:30. But next month, it will be on a Friday, and it will occur from 10 to 11:30 a.m. And it will focus on compassion, fatigue, and employee wellness. If you're not able to join, it will be recorded and posted on our website. So today, as I mentioned earlier, we will be looking at healthcare delivery evolution in response to COVID-19. We've got a lineup of amazing speakers. We have Kim Stopika Dobbs from the Office of Program Operations and Local Engagement. She's going to be giving us a CMS regional perspective. We've got Manuel Solano, who is a program director with the Community Health Council of Wyandotte County. We have Yasser Samor, who is a resident physician at the University of Missouri, Kansas City, who's going to be giving us a research perspective. And then Rebecca Anderson and Deborah White Sanchez, who will be providing us with a federal qualified health center perspective. And then we've got Stacy Farr, who will be facilitating our question and discussion session. Throughout the presentation, if you have questions or comments, please use the chat feature to put those in there. And then that way we will make sure that those get answered by our speakers. We will have question and discussion session at the end of the panels today. And I just want to point you to the kcmo.gov website page, as that has a host of resources for COVID-19 in the Kansas City area. You can look at new case rates by race, by hospitalizations, deaths, positivity rates. You can look at case rates by zip code. You can look at vaccination rates with regards to first dose and complete vaccinations. And then you can also look at the average rates by days and death rates as well. And so that's another resource that we want to point you to. So I am going to introduce Kim Stopeka-Dobbs, who's a regional administrator with the Office of Program Operations and Local Engagement, local engagement and administration for the Centers for Medicare and Medicaid Services. She is going to be giving us a CMS telehealth update. Welcome, Kim.
Thank you. And it's great to be with you all this afternoon. I will go ahead and share my screen and we will get started. So as was mentioned, my name is Kim Stopeka-Dobbs and I'm the regional administrator for CMS in Kansas City, and I'm honored to be with you here today and address these telehealth updates. So as you may be aware, the calendar year 22 Medicare physician fee schedule proposed rule was issued on July 13th, 2021. There's a wealth of content in the proposed rule, but today we're focusing solely on the telehealth related provisions. As a note, CMS seeks public comments through this proposed rule process. So at the end of the presentation, I included a link to the proposed rule. You can use the same link to provide comments on the proposed rule, which are due by 5 p.m. on September 13th. So I encourage you to comment as desired. So a little bit of background. I just wanted to remind you what the Medicare telehealth statute allows under normal circumstances. Obviously pre-pandemic, Medicare telehealth services are subject to geographic site of service, practitioner, and technological restrictions. Except for a few exceptions, telehealth was limited to rural areas designated by HRSA, and beneficiaries had to travel to an originating site, a healthcare facility, to receive telehealth services, and telehealth services had to be furnished via two-way audio-video communications technology. As you're aware, during the public health emergency, CMS has significantly expanded access to telehealth services through the Section 1135 waivers and flexibilities. Under the 1135 waiver authority, Medicare beneficiaries can receive telehealth services in their home, and there are no payment restrictions on distant site practitioners furnishing Medicare telehealth services from their home during the public health emergency. Before COVID-19 PHE, only 15,000 fee-for-service beneficiaries each week received a Medicare telemedicine service. Interestingly, between mid-March and mid-October of 2020, nearly 39% of Medicare beneficiaries received a Medicare telemedicine service during the public health emergency. This percentage is obviously out of date and likely much higher as we speak 10 months later. So the current flexibilities. So in terms of the current healthcare flexibilities under the PHE, the CARES Act broadened the authority under Section 1135 of the Social Security Act to allow for additional practitioners to be eligible to furnish and bill for telehealth services. So this allows physical therapists, occupational therapists, speech language pathologists, and others to furnish telehealth services. Also, through the authority granted under the CARES Act, CMS waived the requirements of the telehealth statute to the extent they require use of video technology for certain services. This waiver allows the use of audio-only equipment to furnish services described by the codes for audio-only telephone evaluation and management services, behavioral health counseling, and educational services. There is a telehealth list on the CMS website that lists all of the codes eligible for telehealth and whether they are eligible for audio only. And I did include the link at the end of the presentation. So in the 2022 proposed rule, CMS is not proposing to add any additional services to the telehealth list. So in calendar year 21 physician fee schedule final rule, CMS created actually a third category of criteria for adding services to the Medicare telehealth services list on a temporary basis following the end of the PHE for the COVID-19 pandemic, known as Category 3. This new category described services that were added to the Medicare telehealth services list during the PHE for which there is likely to be clinical benefit when furnished via telehealth, but there is not yet significant evidence available to consider the services for permanent addition under the Category 1 or 2 criteria. So services added on a temporary Category 3 basis would ultimately need to meet the criteria under Category 1 or 2 in order to be permanently added to the Medicare telehealth services list. CMS is proposing to allow the Category 3 services to remain on the telehealth list to the end of December 31st, 2023, so that there is a glide path to evaluate whether the services should be permanently added to the telehealth list following the COVID-19 PHE. So, for example, to develop evidence to support the clinical benefit for permanent inclusion on the telehealth list. So the Category 3 services that were added in calendar year 21 in the physician fees schedule final rule code included services such as home visits, emergency department visits, therapy services, psychological and neuropsychological testing, and critical care services, just to name a few. Again, the complete list of Category 3 services is on the 2021 MPFS final rule. So if we think about more recently, the Consolidated Appropriations Act, in the proposed rule, CMS is implementing some provisions of this act, including a few provisions pertaining to Medicare telehealth services. Specifically, Section 123 of the Consolidated Appropriation Act removed the geographic restrictions and added the home of the beneficiary as a permissible originating site for telehealth services when used for the purposes of diagnosis, evaluation, or treatment of mental health disorders. So the CAA requires that there be an in-person non-telehealth service with a physician or practitioner within the 6 months prior to the initial telehealth service, and thereafter at intervals as specified by the secretary. So CMS is proposing to require an in-person non-telehealth service be provided by the physician or practitioner furnishing the mental health telehealth service within 6 months prior to the initial telehealth service and at least once every 6 months thereafter. CMS chose this interval because it's concerned that an interval of less than 6 months may impose potentially burdensome travel requirements on the beneficiary, but that an interval greater than 6 months could result in the beneficiary not receiving clinically necessary in-person care or observation. So when we think about expanding access to telehealth services, as part of the expanded access, CMS is proposing to allow for audio-only communication technology for mental health services furnished through telehealth to established patients. CMS is proposing to limit the use of audio-only communication technology to mental health services furnished by practitioners who have the capability to furnish two-way audio-video communications, but where the beneficiary is not capable of using or does not consent to the use of two-way audio-video technology. And CMS is proposing to require use of a new modifier for services furnished using audio-only communications, which would serve to certify that the practitioner had the capability to provide two-way audio-video technology, but instead used audio-only technology due to beneficiary choice or limitation. So in allowing for audio-only communications, CMS believes the mental health services are different from most other services on the Medicare telehealth services list, in that many of the services primarily involve verbal conversation where visualization between the patient and furnishing physician or practitioner may be less critical to the provision of services. You are likely aware that the Consolidated Appropriation Act also created a new Medicare provider type called rural emergency hospitals, which would be effective in calendar year 2023. As part of that, the requirements for this type of hospital are listed here, but they include the requirement to furnish emergency department outpatient and other services that do not exceed an annual per patient average of 24 hours. CMS is also proposing to include rural emergency hospitals as a permissible originating site for telehealth services furnished on or after January 1st, 2023. So the same day that the provider type would come online, which means that a beneficiary must be physically present at the facility to receive telehealth services from the distant site practitioner. Another area that came up during the PHE was virtual supervision. So outside the circumstances of the PHE, direct supervision requires the immediate availability of the supervising physician or other practitioner, and CMS has interpreted this immediate availability requirement to mean in-person physical availability, i.e. non-virtual. However, in the 2021 final rule, CMS finalized the direct supervision may be provided using real-time interactive audio and video technology through the latter of the end of the calendar year in which the PHE ends, or December 31st, 2021. So currently, CMS is soliciting comment on whether the current timeframe for continuing this flexibility remains appropriate, or if this timeframe should be extended through some later date to facilitate the gathering of additional information to assess the implications of a permanent change in policy. So CMS is also seeking comment regarding the possibility of permanently allowing direct supervision through virtual presence for only a subset of services, as CMS recognizes that it may be inappropriate to allow direct supervision without physical presence for some services due to potential concerns of patient safety if the practitioner is not immediately available in person. CMS is also seeking comment on whether a service level modifier would be required to identify when the requirements for direct supervision were met using two-way audio video communication technology. Also part of this was virtual check-ins. So in calendar year 2021 final rule, CMS finalized payment for a new HCPCS G code to describe a virtual check-in that involves an 11 to 20 minutes of medical discussion to determine whether an in-person visit is necessary. So in calendar year 2022 proposed rule, CMS is proposing to permanently adopt coding and payment for this virtual check-in code in recognition that additional time may be needed to assess the necessity of an in-person service given concerns over exposure or to illness beyond the duration of the PHE. In relation to rural health clinics and federally qualified health centers, the CARES Act authorized RHCs and FQHCs to furnish distant site telehealth services to Medicare beneficiaries during the COVID-19 PHE. This flexibility is set to expire at the end of the PHE. However, CMS is proposing to allow RHCs and FQHCs to report and receive payment for mental health visits, including audio-only visits when the beneficiary is not capable of or does not consent to the use of video technology. This proposed expansion of payable modes of mental health services furnished by RHCs and FQHCs aligns with the expanded availability of telehealth for mental health services under the physician fee schedule as authorized by Section 123 of the CAA, which I just discussed a few minutes ago. Another area where this has come up is the opioid treatment program payment policy, or OTPs. So CMS established a new Medicare Part B benefit category for opioid use disorder treatment services furnished by opioid treatment programs, or OTPs, during an episode of care beginning on or after January 1st of 2020. CMS is proposing to allow OTPs to furnish counseling and therapy services via audio-only interaction after the conclusion of the COVID-19 PHE in cases where audio-video communication is not available to the beneficiary, including circumstances in which the beneficiary is not capable of or does not consent to the use of devices that permit a two-way audio-video interaction. CMS is proposing to require that OTPs use a service level modifier, much like the previous ones, for audio-only services billed using the counseling and therapy add-on code, and document in the medical record the rationale for services being furnished using audio-only services in order to facilitate program integrity activities. So finally, this is a link, a slide of resources. So links to press releases, fact sheets, and final rules. And the final rule link is also where you can go to provide comments on the proposed rule. And then also the two at the bottom are specifically telehealth related information from CMS. And so just in closing, I would just say it's important to note that CMS does not have the regulatory authority to make permanent the expansion of telehealth services authorized under the PHE. That would have to come through statutory change. So like many of you, we are waiting to see what congressional action holds in that realm, but we will stay tuned. So with that, I will stop and hand it back over to Christina. Thank you.
Thank you so much, Kim. And again, if you have questions or comments, please use the chat filter, or we will have discussion after our panelists. Next up, we have Dr. Manuel Solano. He is the Program Director from Community Health Council of Wyandotte County, and he will be providing a community-based organization perspective focused on the role of community-based organizations in healthcare delivery in a COVID-19 world. Welcome, Dr. Solano.
Thank you for having me today. And our organization is one of those organizations that has been very much impacted by COVID-19 and what is happening right now. We were an organization that were focused on policy, and we were pushed all of a sudden to become an organization to serve and provide services. So that was a humongous big change for us. And of course, changing and from an organization of 5 people to an organization of 36 right now, and create a whole infrastructure for in order to respond to the needs with COVID, affected us a lot, and we learned a lot within this particular experience. Within this, our challenges have been to adapt at the pace of the changes in the community needs. So for us specifically, every single day during the last 8 months, we have to face the unexpected. We never knew what is going to happen tomorrow. And just to give you a couple of examples, we were supporting the health department with volunteers in order to provide vaccines. But the health department cannot respond as quickly as the community-based organizations providing volunteers to vaccinate people. So we were supporting and helping them on this. Then after all the peak in the vaccines went away, the problem was, okay, these contracts with the medical providers and the healthcare providers were signed for 6 months, and they have nurses providing vaccines, but now they have to lay them off because we didn't have enough people going to the sites in order to get vaccines. There, the community-based organizations have to help now recruiting and taking people to the different sites to be vaccinated. But at the same time, the healthcare providers and the numbers of providers were coming down because they were not needed. And now we have this peak where we need services again. So the main importance and the main the core of the community-based organizations in situations like this is to be flexible, that we are flexible enough to support the services needed within the different levels of intervention. So that is one of the main reasons. And we are a thermometer to find out what is happening in the community, specific communities, in order to address the needs faster than many others. So those are kind of the key lessons and what we learn within this. the flexibility of the community-based organizations is big, and our capacity to respond to crisis is high. That is mainly my comment. So I'm open to questions now.
Thank you so much, Dr. Solano. We are going to have people use the chat function for questions and comments, and then we'll hold a question and discussion forum at the end. So again, if you have questions, please use the chat function and Dr. Solano will address those. Next, we have Dr. Yasser Samor. He is a resident physician in the Department of Internal Medicine at the University of Missouri, Kansas City School of Medicine. He is going to provide us with a researcher perspective that's going to focus on outpatient management of heart failure during the COVID-19 pandemic after adoption of a telehealth model. Welcome, Dr. Samor.
Hello, everyone. How are you? Should I share my screen or?
Yes.
Okay. All right. Can you see it now?
We sure can. Thank you.
All right. Perfect. So my name is Yasser Samor. I'm a third-year internal medicine resident at the University of Missouri, Kansas City, and St. Luke's Hospital. I have no disclosures. Today, I'll be talking about outcomes in the outpatient management of heart failure during the COVID-19 pandemic after adoption of a telehealth model in our institution. So the COVID-19 crisis created lots of challenges to healthcare delivery, especially in the initial phases of the pandemic, which led to dramatic transformation in how we delivered healthcare to patients, especially in the outpatient setting. There have been reports about excess mortality in the year 2020 compared with the similar durations in prior years, with only about 2/3 of those that extra mortality related to COVID-19 infections. So we tried to explore, and we think that the remaining part could be because patients were delayed in their presentation for other non-COVID related conditions because of the stay-at-home orders and anxiety about presenting to hospitals during that phase. So because of that, telehealth has become an essential method in conducting outpatient visits during the pandemic. In March 2020, our healthcare system, the St. Luke's healthcare system, that included 18 different cardiology clinics, adopted a telehealth-based model for outpatient care during the pandemic. We sought to compare whether virtual visits versus in-person visits and whether they had like different outcomes among patients with heart failure. We also compared outcomes between video versus telehealth visits. We identified patients who with heart failure who were seen at St. Luke's Health System cardiology clinics between March 15 and June 15 of 2020, and compared these patients with heart failure patients seen during the same time period in 2018 and 19. We looked at some variables and extracted data from EPIC EMR using the ICD-10 codes of primary and secondary heart failure diagnosis. And our main outcomes in the study were emergency department visits, hospitalizations, need for ICU, and mortality. We included a little over 8,000 patients with heart failure that represented 15,000 clinic visits between March 15 and June 15 in 2018, 19, and 2020. Patients were seen at 16 different cardiology clinics by 113 providers, including 66 cardiologists in our practice and 47 advanced practice providers. And we looked at like subsequent visits after the index clinic visit to 16 ED locations and 12 hospitals in our health system. These are baseline characteristics. Before matching the groups, we had 10,000 patients in 2018-19 and 5,224 patients in 2020. And after matching, we had like similar groups to like remove any or adjust for any differences at baseline between the two groups. Interestingly, in this table, like we looked at appointments confirmed within 48 hours before the visit, which we used as a surrogate for whether this was an urgent visit or not. And we found that almost 16% of the patients seen in 2020 scheduled their visit within 48 hours of the appointment, which may indicate like a bigger proportion was urgent care visits compared to 2018-19. And also patients were slightly younger in 2020 compared with 2018-19. Here we look at the proportion of office versus virtual visits. As you can see, in 2018 and 19, all visits were conducted in person. And then in 2020, in the first 3 months after we rolled the telehealth model, almost 90% of the patients were seen in virtually via like telephone or video capabilities. And these are the numbers of the actual numbers of the visits conducted in person versus telehealth. And here we look at in the first 2 weeks after we adopted the telehealth models, there was a spike in the telehealth visits. And during the study period in 2020, there was some decrease in the telehealth visits and return of gradual return of the in-person visits. We also looked at how many of these visits were seen by physicians versus advanced providers. And it was similar proportions in 2020 versus 2018-19. We also tried to break them down by video, office, and telephone. And physicians slightly saw more patients with video, like 29% versus 22% for APPs. And telephone was more commonly used by APPs, like in 68%. We also looked at how many of these heart failure patients were seen by heart failure providers or specialists versus other non-heart failure cardiology providers. Also, the proportions were very similar in 2020 versus 2018-19. So an unadjusted analysis, according to the year of the visit, we found that in 2020, which is the red lines, there was fewer ED visits and hospitalizations in 2020 compared with 2018 and 19 at both 30 days and 90 days from the index clinic visit. And then at 90 days, there was higher need for ICU and higher all-cause mortality in 2020 compared with 2018 and 19, despite no difference at 30 days. We did propensity matching to adjust for some baseline differences between the two groups, but obviously there were some unknown confounders related to the pandemic that we were unable to adjust for. And we found that virtual visits done in 2020 still had fewer ED visits and hospitalizations at 30 days and 90 days from the index clinic visit compared with in-person visits, which were done in 2018 and 19. However, when we compared ICU admissions and all-cause mortality, we didn't find any differences at either 30 days and 90 days between the two groups, between virtual visits and in-person visits. Then we looked at, we tried to compare video versus telehealth visits. And here we broke them down, like as you can see in the first 2 weeks, almost all of the telehealth visits were done by telephone, but then over time, as providers became more confident with the telehealth visits, we started to see more and more video visits used during the study period. And as we described in the previous figure, also during the last part of the study period in 2020, office visits started to come back again, like in-person visits. And then we looked at some predictors of access to video telehealth visits, like with regards to demographics and socioeconomic status. And we found that patients who were older and African Americans, and patients with no spouse or significant other, patients who lacked college education, and patients with lower income were more likely to use telephone visits and less likely to use video visits. And then we looked at the same outcomes for video versus telephone visits, and in unadjusted analysis, we found that video visits were associated with fewer urgent encounters after the visit compared with telephone visits, but there were no differences in mortality. And then when we adjusted for baseline differences, 30-day outcomes were similar, but at 90 days, there were still fewer urgent care encounters after video visits and telehealth visits, indicating maybe some better performance for video visits as compared with telephone visits. We have some limitations in our studies retrospective from a single system. There could be some inaccuracies because of relying on the ICD-10 codes and data pull from the EMR. And we could have missed some ED visits and hospitalizations outside our health system. But again, like, we have lots of locations in our health system. It's one of the biggest healthcare systems in the area here. So we think that we've captured most of those urgent care visits. In conclusion, there was avoidance of care during the early phase of the COVID-19 pandemic, with fewer hospital encounters and higher 90-day mortality and need for ICU as compared with prior years. A telehealth model for outpatients with heart failure allowed for distanced encounters without increases in acute care or mortality. There were demographic and socioeconomic disparities among patients who connected with telephone versus video capabilities. And the lack of video capabilities was associated with increased subsequent encounters after index outpatient visit. And as the pressures of the COVID-19 pandemic abate, our data suggests that telehealth visits in patients with heart failure can be safely incorporated into clinical practice. This is our group. Thank you so much.
Thank you so much, Dr. Samor. Next, we will hear from Rebecca Anderson and Deborah White Sanchez, and they are from Kansas City Care Health Center, and they will be providing a federally qualified health center perspective, focusing on using community health workers as extenders of the healthcare system to impact the community. Welcome, Rebecca and Deborah.
Thanks for having us. I am Rebecca Anderson. I'm with KC Care Health Center. I am our Director of Care Coordination. So I'm over our CHW program, our community health workers, and also our health insurance navigators. And I'm going to talk about our lessons learned because, as we said at the beginning of the call, I would say lessons learned during COVID, but we're still in the the fire of COVID. So it's ever evolving lessons that we are learning. So our program model, just a little bit about our program. So the program started in 2011. We have been doing CHW work since then. We serve our clinic. We serve hospital systems, KU and St. Luke's. We are in St. Luke's in their internal medicine using our CHWs to try and engage with patients when they're in clinic. And then our CHWs at KU are in the hospital system. Deborah White, who is here with me, she's a CHW and she works for Children's Mercy. So she works with the pediatric population. We also work with Mark, which is our older adult population. And then we have some community-based organizations that we work with that we receive referrals from. So we have kind of gone back and forth with our model over time. And at the beginning of 2020, where we were is we have an assessment that we do with all of our patients. We have a pediatric assessment, we have an adult assessment. And it's really a social determinant assessment. It's called the Arizona Self-Sufficiency Matrix. And our goal with that is really to find out from patients where they score along the continuum. So are they self-sufficient in the areas like transportation, applying for insurance, seeking medical care, even being health literate is something that we look at. And then based on how they score, we know where they fall and if that's a task the CHW could work on. So that was our standard model. We would do this assessment, we would find patients who needed the service, and our CHW is really like kind of our thought at the beginning of 2020, or really since we've been doing this for a long time, is, you know, we find patients who need that hand holding through the system. There's a lot of patients who don't need that. We can give them information, they can navigate that on their own. But there is a group of patients who are really designed for a CHW, and that, you know, they need someone to go into the home. They need someone to go over all their documents with them and do that hand holding that other professionals don't do. But what pretty quickly changed and what we realized once COVID hit is that patients no longer wanted that level of care. And the reason they didn't want that level of care is because people were afraid to have other people in their homes. People were afraid of going into healthcare settings. And so one of the things that we had to do, and kind of our lessons learned, is we had to pivot and make this what we call episodic, where we find information for patients, we provide those patients with the information, and then what we ended up standardizing is then we follow up with those patients in 2 weeks to see if they were successful in being able to do that task. If not, then they can become enrolled in the program. So that's one of the things that we pretty quickly had to change. The other thing that became so apparent to me as we were doing the social determinant screening is we were coming across patients and we were assessing for things originally, you know, like furthering your education, like we're trying to change people's socioeconomic status, and what are some of the things that feed into that, like furthering education. So we would ask patients, you know, do you want to complete your GED? Are you interested in trying to look at college courses? And patients were in survival mode. Like there was no way, shape, or form that people were like, you know, I'm going to go out there and get my college degree right now, or I'm going to work on my GED. And so we ended up having to change our entire assessment, and the assessment that we use now, it's our COVID assessment. And we even added a COVID domain, because the other thing that we're experiencing in the community, and even among our own team, which has been kind of interesting, is there's so much misinformation about COVID. And so we put that as a task on the CHWs to try and assess patients for their understanding of, what do I even do if I contract the illness? You know what I mean? Like, do I run to the emergency room? Do I stay home? So we added that as a domain we're assessing for. We also applied for grants to be able to give our patients hotspots. We knew that we track hospital data, and we knew that patients were not showing up to the hospital because the country miraculously got better with health, right? Like diabetes wasn't cured, hypertension wasn't cured, all the things that people were going into the health before going to the emergency room for, people were scared to go to the hospital. And so what we wanted to do is to make sure that patients felt comfortable receiving healthcare in a safe environment. So we got grants for hotspots that we give patients. One of them was through the state, and they had unlimited data. And then we applied for a small grant to be able to give to the community that had plenty of data for patients. You know, part of this was like, how do we get patients to appointments? But then there's this mental health issue too of isolation. So we wanted to make sure these hotspots had enough data so that if people wanted to stream movies or Google and look up things, that they were able to. And then kind of like the last couple of things I'm going to talk about, and then I'm going to hand it over to Deb, because she's really the patient expert in what this has looked like working with patients over the pandemic. We got COVID kits, with the goal that if we found patients who had tested positive, what we really wanted to do to try and help, you know, people just freaking out and running to the hospital was to give them the tools that they needed to self-monitor at home. So our COVID kits have oximeters in them, they have masks, and they have hand sanitizer. And we give those to patients. If a patient tests positive, our doctors in our clinic also are aware of those. that we can give patients so that then the patients are monitoring oxygen levels and they're able to give that communication back to the doctor like, hey, I'm dropping below 90. What do I need to do? But because we know a lot of our patients, you know, oximeters are not crazy expensive, but with limited resources and people losing their job, that is an expense that people don't have. So those are some of the strategies that we've used. As far as like in long-term engagement, as the virus kind of ebbs and flows, as we all are seeing it happen and play out in real time, we have to put different safety measures in place for our staff. And so we had gone back to doing home visits and meeting patients in the community and really like more of a normal. But now with Delta surging, what strategy we implement is we do what's called porch visits or outside visits. And then we do have conversations with patients beforehand, you know, can I bring you a mask? Just really trying to reinforce those pillars of safety so that we can keep both patients and our staff safe. And then one of the last thing I'll kind of touch on is we are, as a health center, we are mandating COVID vaccines. We just feel like that's a good decision, both for our CHWs, our medical staff, obviously, but also as a way to protect our patients. So I'm going to hand it over to Deb so she can share her expert piece as a CHW, some tips and tricks she's used during COVID to work with patients and what has helped her. And then we can get questions at the end.
Thank you so much, Rebecca. Thank you, everybody. I appreciate you all taking your time to listen to me. So I work at Children's Mercy Hospital, as Rebecca said. I'm very thankful that before COVID hit, I had established relationships with the people who actually hand me the patients. And when I say this, at Children's Mercy Hospital, they do an assessment as well. And say they have a patient, for some reason, they're eligible for food stamps, but for some reason they aren't getting them. And so maybe they'll send that patient to me. Well, I get to delve into deeper why the patient is not applying for food stamps, or maybe they're illiterate, maybe there's some fear. I actually had a new patient today that I met.
Hey, Deb, you cut out.
I think she's frozen.
Oh man. Let me put a message to her in the chat.
One of the new things that we have to deal with during COVID. So it looks like she dropped off, and hopefully she will be able to rejoin us because it sounded like she had some very important information to share with us. Rebecca, did you have any other?
Sure, yeah. One thing I forgot to talk about is one of the things that we tried to work on, and we're still working on, because, you know, we're back to this dynamic where people are not coming in person, or again, they're scared to go to the doctor. They're scared to like seek care if they need to. So really taking data out of our EMR and targeting patients who are high risk. So who are those patients who could get COVID and would be high risk, who might not be coming into the doctor? So we pull lists and we look at our diabetic patients with A1Cs above 9. We've even done some outreach to our patients that have mental health issues that we know, you know, might be self-isolated, and just do some like checks on them, like how are things going, especially with COVID and not being able to be around other people. And doing those like preventative calls has been super, super helpful. We've caught a lot of people who are like, you know what, like haven't been taking my medication right, like I need to get into the clinic, or you're right, I haven't done my labs. And one of the things the medical team decided to do is drive-through labs. So they were piloting drive-through A1Cs where patients could come and get their A1C checked without having to come in the building. So we're really just trying to be as innovative as possible with patients, knowing, you know, there's this healthcare that has to be happening. It's like this revolving door of how do we keep people healthy? And it's either through like lifestyle interventions or medications, or sometimes both. But if we don't see them for long periods of time, you know, we don't know what's going on. So outreaching those patients and trying to get them back in our doors, whatever that looks like, whether it's telehealth or appointments or drive-through labs. So that's one of the other things as a clinic we've been working on.
That's really exciting. Trying to see if she's jumped back on.
I haven't seen her jump on just yet.
Okay.
So we could probably start Q&A and
Yep. So I will go ahead and introduce Dr. Stacy Farr. She is with the Kansas City Quality and Value Innovation Consortium. She is also a research assistant professor at the University of Missouri, Kansas City. Welcome, Stacy.
Oh, thank you for that, Christina. And thank you, everyone, all of the speakers. This is a really interesting, diverse panel. And, we really appreciate just when we take one of these topics, and COVID, right, is new for all of us, how hearing, the experiences, the lessons learned, the, the challenges, successes, and, policy, everything that relates to, these new surprising a pandemic that kind of changes everything for everyone. But hearing from those different perspectives is just so helpful. And so, I think what we do during this time, we have actually quite a bit of time for Q&A today. And so anyone who has a specific question is certainly welcome to, unmute themselves and put their video on, say hello to the group, and ask the questions aloud. Otherwise, we, have a little bit of comment in the chat, but we don't have necessarily a lot of questions yet. I can kind of read where we were at in the chat for anyone who doesn't see that, but otherwise, if anyone has any questions and would like to unmute themselves, we certainly welcome that for any of the speakers. And while you're all compiling your thoughts, I'll just read, I guess, at least what we have in the chat so far. And so I know that from Dr. Yasser Sammer, his presentation on kind of what was seen, during from the hospital side, in terms of after, implementing telehealth and kind of what happens, to heart failure. There was a question in the chat about having that data, to help assist CMS with determination. And, I know Kim did respond, and she can also speak to, I guess, her response as well. But knowing that,
I'm happy to jump in if you'd like me
yeah,
to.
Sure. I was like, I can start to read what you wrote and
No
put my own
worries.
thoughts, but I'd be happy to hear from you on.
Yeah. So, that's a great question. So, and I guess just a little bit of context too, and I should provide that. So, in my role, so as the regional administrator, and I'm with the specific office called Local Engagement and Administration. And so in our office in Kansas City, so CMS has 10 regional offices, and then we have our main office in Baltimore. That's the big one with lots of people. And so in our regional offices, particularly in my particular group in Local Engagement Administration, we work specifically with stakeholders in our 4-state area, which covers Iowa, Kansas, Nebraska, and Missouri. And so we're working with both on two sides. We're working with providers, and we're working with and connecting to community-based organizations, right? Because we're trying to get messages out and get information out about CMS programs and just public health messaging to both providers and associations, as well as consumers, right, on Medicare, Medicaid, and Marketplace. And so we're kind of simultaneously doing that. So as we're engaging what we call stakeholders, right, as we're engaging those stakeholders and particularly providers in this case, one of the things that obviously we talk about a lot and that has come up a lot in the recent past is telehealth. And so, we talk a lot about, what has the experience been, what has been particularly helpful in telehealth, in these flexibilities. And that's where, as we talk to maybe rural providers, right, we heard a lot about broadband, right? I don't have the broadband capability to do video. I can only do audio. And so, you know, we've heard that feedback. And so we've just taken whatever kind of different feedback we've heard along the way. And part of our job is to really roll that up. So we do try to do that. But I will say that's the unofficial way of doing it, if you will. And so you're right. So that if the official way to do it, the official way to provide comment is through the notice, through the notice of rulemaking and that link that I put on there through the federal registrar. So, you know, I'm always happy to have people reach out to me with information too, and I'm happy to pass those things along. But as far as like commenting and you know and having that officially part of like what you would like to see and what data would support that, it's helpful to put that through that comment process.
Yeah, thank you very much. And that definitely helps clarify. Looks like a few comments came in while you were speaking as well, Kim. There's one comment that says, you know, first time attending session, want to thank you all for the work you're doing. Connecting patients to the available resources and CBOs is incredibly important work. And, you know, a comment about, you know, these findings that we've even, you know, found regionally, Dr. S'more's work, you know, how wonderful that can be to submit to the comment period. And also just, I guess that's a broader encouragement to the, you know, local provider associations or anyone who has, you know, data or experiences with it. It's always helpful to submit those through the public comment period. And those URLs are in the chat here. So for the some of the proposed rules, and I think also in the slides that Kim had, and those will be live on our website in a couple of days too. And then there's another question from John Fitzpatrick, who said for Rebecca, with deeper levels of engagement for community health workers, it seems that there will be greater use of technology. Do you see the changing CMS rules as helpful or not in terms of the impact that we'd see on patients and clients? So for example, once community health workers get to homes more readily, they might be doing some of the services that your pop-ups are now doing. It looks like you also responded, but Rebecca, would you like to address that comment?
Sure. Yeah, I mean, I actually see a tremendous role for CHWs and the use of technology, and especially like medical devices and being able to put that stuff in patients' home, that information that feeds back to the provider. You know, I think that offers better monitoring for patients. I think that offers better patient engagement. We know some of these patients, it's hard for them to leave the home. And I think CHW really is like the perfect role to be able to do that. They have those connections, they have the trust of the patient, they have those skills or can easily be trained on those skills with technology. And then just getting into the patient's home to help the patient set that up. That's actually something that we will be piloting pretty soon. There's a project that is going to be taking medical care to patients' homes, patients that we have seen and know are not going to the doctor for whatever reason. And so we are going to reverse that and make sure that all the care is being taken to the patient's home, and CHWs are going to be the hybrid for that, where they're putting some of these self-monitoring devices in the patient's home, helping get those set up, making sure that information is being fed back to the physician. And then whether the doctor comes into the home, or we make sure that they're using, you know, those hotspots to link to like telehealth, so that the patients can get those medical visits. So yeah, I totally think that that is a role for CHWs in the future. I actually think it's like a perfect fit, and I'm here for it. I'm so excited.
That's great. I mean, I would be interested to hear, I guess, from all stakeholders. I mean, I think particularly, I guess, Rebecca, some of the things that you guys have seen in the field, especially with, you know, patients with you know, socioeconomic status and SDOH needs, but also on the CMS side. I think, you know, a lot of you could speak to this, but I would like to hear just what we think the biggest, you know, gaps are that, you know, maybe have not yet been addressed through public rulemaking or through, you know, the way in which you've kind of tried to address the gaps that you can with Casey Care, Rebecca, and your group, but, you know, just to better understand and the lessons you've learned, Dr. You know, S'more, from your research, but what we think are some of the things that have not yet been addressed that we could, you know, think through together.
Yeah, I can touch on that and then let whoever wants to take it, talk about it too. So we've seen some really interesting things pop up as both like interesting in that it's kind of surprising, like what spots patients end up in. So at the beginning of the pandemic, patients certainly were worse off than when they changed the unemployment rule and patients started getting more money. And then also when they increased food stamps, this is one thing that Deb was going to talk about. She said that she has patients right now that are actually doing better than they were like at the very beginning of the pandemic, just based on some of the rules that have been in place. So, my concern is once some of this stuff goes away, where that leaves patients when they're not getting extra food stamps, when there's not the rules in place about evicting patients, the unemployment, people are not getting that extra compensation. So like where people land when that stuff happens. But then there's really just been some outlier stuff that you wouldn't think of. We had a CHW it was with a project through Mark, and they were focusing just on COVID positive patients. And so we would get patients who tested positive from the health department that were then referred to us. And really we were trying to make sure, like, what are the services that you need? And it was a collaboration with 5 other care providers that also got funding, and their funding went directly towards the items that patients would struggle to get. So I have to quarantine and I need food for 2 weeks, right? Like I cannot leave the house and I don't have anyone that can deliver it. And so it was set up that organizations had the ability to be able to get that food to the patient's houses. Or if they needed rental assistance, they could get that rental assistance. But some of the gaps that people like really didn't think about is, we had patients who were like, I had to take off work because there was one family in particular, and the son got COVID, the dad got COVID, and the mom got COVID. And the son ended up, the mom passed away and the dad got really, really sick and needed home health. The son luckily made it, but then they had to start having conversations about, there is no income coming in. How do we pay for this funeral, for example? People aren't funding things like car payments. And so patients then become scared that they're not going to have transportation. So I think some of like the conversations, this is just my opinion, but that we need to continue talking about are not like what exists, because I think there are things that exist for patients, but like what doesn't exist that people aren't addressing. And it's things that you honestly wouldn't think about. Like some patients called us and they're like, I don't even have a thermometer. Like, what do I do? I can't monitor my temperature. So that's my 2 cents on that.
Thank you. Very helpful.
I do see that Deborah just jumped back on.
Oh, it would be great to have her finish her comments if she's able to. Sorry for the technical difficulties, Deborah.
It's okay. I'm like, what's wrong with my phone? and I'm looking around, and my husband finally, I'm like, he said, what? I'm like, I don't understand. He said, then he got a text and the Wi-Fi is out in this area. And he said, he said, yeah. And so then he showed me how to do it on my phone, which I forgot because I was frantic. So I didn't remember. Oh, I'm sorry.
Well, welcome back. And so you were telling us about an experience with a patient you had met today.
Yes, she actually, for 3 of them, she gets $741 a month. That's what they're living off of. She's eligible for food stamps. She actually had gotten sick, gone to the hospital, and was diagnosed with diabetes. And then I said, well, how are you all eating? She says, well, we've been going to pantries in the area. I said, that's all stable. That's the other food that you eat is a shelf-stable food. So it's high in salt, it's high in preservatives. And she says, that's probably why I'm sick. I said, why? Okay, how about we apply for food stamps? And she says, well, I think my husband, she whispered, is embarrassed. And I said, that may be true, but I think he'd be more embarrassed if if this killed you. And so I'm working. So this is the kind of things that I have going on with the families. One thing that I did during COVID, when we were talking about what we did during COVID, was any provider that I actually referred somebody to, I called first to find out what they were doing differently because of COVID. And so then when I called and talked to the client, I would relay what was going on so they wouldn't be surprised or they would know what to expect. And I also sent thank you note. Everybody who I worked with in the community that was exceptionally helpful. The Housing Information Center, the community engagement specialist at the library. These people were exceptionally helpful. So what I did, I sent them thank you notes and thanked them for helping my particular clients that I sent to them. Because I think during COVID, one thing we had to do was make deeper connections with people to get anything done. Because we weren't physically connecting, so we had to find a way to actually deeper connect with people. Yeah. So that's one of the things that I did. Oh, thank you for letting me back in.
Thank you for enduring and for joining us. And I think you bring up a good point. I think one of the things that we've also seen is a lot of these services are extremely taxed during COVID. And so it's true that those words of thank you and appreciation go a long way. And folks remember those very much so, because people are tired, they're scared. There's a lot of uncertainty. And so we have kind of lost our sense of kindness to some degree. And so I think you raised a really great point, Deborah. Thank you.
Yes. Thank you so much. So I think we have another comment in the chat directed toward Kim. There's a question from John Fitzpatrick of KC Digital Drive about, in this region, we are certainly sensitive to rural health deficits, but we also see similar access issues in depressed urban areas. Do you see the pre-PHE rural urban distinction going forward in telemedicine?
That's a great question. And I totally agree. I mean, I think we saw just, I think about everybody going virtually for school, right? Very similarly, right? We saw, sure, it was an issue in rural areas, but we had issues with, but there was also a very big divide, for lack of a better word, too, with urban areas that couldn't afford the Wi-Fi access, or if you have multiple kids, how are they all on the same computer at the same time and splitting that? And so there's a lot there's a lot there. I do think, interestingly, with the proposed rules, there really does seem to be less of a distinction there. The proposed rules have, and that those category 3 services, I think there's really more of a look at which services, right? Which services make sense for telehealth, and if it's possible for audio only and those kinds of things, and less to do maybe with location. And then I think as well, even within, they do some with like the rural emergency hospitals, the new provider type there, and obviously that's rural. But places like FQHCs, right, which may be in the urban areas, right? There are particular related telehealth provisions for them. Yeah, so I don't think it's as tied to that idea of, if you're rural and live a long ways away, you're the one who needs telehealth. I think it's a broader thought now.
Great, thank you so much. Anyone else with any questions in the audience? Dr. Samore, is he still on? I'd be curious to hear kind of his next steps and plans with the research that they had done, or if they're continuing that at all.
I'm sorry, I didn't hear the question. Can you say that again?
Curious to hear your next steps and how you plan to, either expand upon, grow your areas of research, or what your next steps are with the work you've been doing.
So we actually submitted the both papers and they got accepted. So with regards to expanding more data, I'm not sure if I think what would have been ideal is to if I'm gonna do like another, actually there is another one that we're doing specific for heart failure patients. Now that you mention it, we're looking at like the initiation and discontinuation of heart failure medications with in-person versus telephone versus video visits. And we found that from the preliminary analysis that the initiation of medications was more common in in-person visits than video, and then video was more than telephone visits. The discontinuation of those heart failure medications was similar among between the groups. So that would be the next step. But I think if we need to do another thing, I think we can look at outcomes in video in telehealth versus in-person visits, all during the pandemic with a more expanded sample size, like during the first year or 2 years, if possible, from our data. And clinical trials would be also very helpful if we can do something like this, like randomize those patients, and whether on single center scale or multi-center study.
Well, it sounds wonderful, and we wish you the best with your work, and congratulations on the papers. That's very exciting.
Thank you so much, Dr. Farr. Appreciate that.
Scanning through the audience and the chat. I'm not sure if I see any others. Any other burning questions? I know you've got them. Unmute and do share.
I just think the challenge is how, how do we take some of these learnings and these novel approaches to care and use them, going forward. And I think a lot of it really is going to be very dependent on the ultimate reimbursement strategies that CMS, I see Tony Sun from United's on, that others take, because it does seem to be very patient-centric, and some of Dr. Samour's work shows safe, and people are effectively triaging those that absolutely need to be seen in person. And, in general, when people are seen virtually, it's less expensive, not just because of the reimbursement, because there's often less additional ancillary testing. And so I think it's really going to be, this was a remarkable natural experiment. And I just wonder whether or not we're really going to be able to leverage this opportunity to think about new ways of designing healthcare delivery that are more patient-centered, as efficient, and more cost-effective. And that's really, I don't know if anybody on the panel would have comments on that, but that's sort of, I feel like I'm watching a Netflix series, and they're ending the series and you don't know what actually happens to the main characters. And so that's what I want to know.
I'll just say, and I don't, unfortunately, I don't think it's very, well, I don't think it's completely concrete, right? But I think from the CMS perspective, as fast as the government can move, I think we are trying to learn along the way, right? I think we are trying to, not just my office, but lots of others, right? Talk to the field continuously, talk to providers, and be able to, understand the challenges, or what's, where the reimbursement rates should be. Just for example, right, with the COVID-19 vaccine reimbursement rates, right, we started at, I'm blanking because it's been a long time ago and my brain is filled with other things, but it's something like $16 for the first dose and something else for the second dose for the administration reimbursement rate. And now we're at $40 per dose, per dose for the administration reimbursement rate. And so, I think that change was able to be made pretty quickly in the grand scheme of things. And so I think we are trying to kind of learn along the way, and hopefully, we are hearing from providers and associations and getting that information, and getting that information back. And again, I think through comments that through the rulemaking process and things like that, we try to inform those kinds of things. So, I think, definitely more to come, right? I think CMS is still learning a lot about, like you said, what is working, what is going to show, evidence down the road, and so that's where things like where we propose to bump out dates like through 2023, those kinds of things, to be able to see if some of those things have evidence for other, those category 3 services. So those are my thoughts.
Yeah, hey, John, Tony's son here, if you all can hear me. So we certainly are aligning with CMS from a payer perspective, along with, from United with CMS, in particular with our government line of business. I think where we're going to see some really creativity is in particularly in our Medicare Advantage, as well as in our commercial populations, to begin to really get very aggressive toward or moving faster toward the sort of a value. What we also saw that during the first part of 2020 during the pandemic was the uptick of telehealth due to the abatement of in-person visits. However, what we saw when in-person came back, the severity of some of the deferred care is quite dramatic. And all the abatement we saw in 20 was somewhat made up by some of the end of the 21 severity of the cases. It will be interesting to see what happens again as we see the second portion of the Delta variant and the waves that we're seeing. I am very curious to begin to see how much faster we can move toward some sort of risk sharing. And I know we're having ongoing conversations about that. Attribution modeling for population health is going to be very, very important as we begin to aggregate that. But those are my general comments, because in order to have good risk sharing models toward value towards risk sharing models, we got to have enough populations to kind of reduce some of that risk. So those are my general comments.
Great, thank you, Tony. Anyone else? I mean, I think we're, I think this is all, I want to stop and pause and thank all of you speakers, not only for, speaking and offering your time generously today, but just knowing, this topic is so timely, so important. We are all, every single one of us here on this call, every single one of us in the community, trying to understand how in the world to live, under this new normal that we're under, and it's constantly shifting and changing. And so with that, that impacts every sector, right? In terms of, policy, healthcare, people's living, working, and everything. And so we just want to thank you all for your time, your continued commitment to helping everyone through COVID, but also, just thank you also as speakers here on this forum, and thank you also for being a part of the KC Quality and Value Innovation Consortium.